Good evening, everyone, and welcome to the EUROGEN webinar series. I'm Michelle Batty, and I'm the manager of the European reference network that we call EUROGEN, which deals with rare urorectogenital diseases and complex conditions. Now, there are 24 ERNs, and they were created and funded by the European Commission since 2017, and they all deal with rare diseases across different medical fields. And Eurogen, well, we're currently a network of 56 healthcare providers in 20 member states, all collaborating together and sharing knowledge to help improve treatment for patients with rare diseases. So, some of our activities, what do we do together? Well, we write clinical guidelines, we collaborate on a registry, which is quite exciting, trying to pull together fragmented data from across different countries for our patients with rare diseases. But perhaps one of the most innovative things is we have a very exciting tool called the Clinical Patient Management System. And this enables us to have cross-border virtual case discussions between our experts on particularly tricky cases, and it's a fully safe and secure environment. Now, Parmida and Darren can give you access if you're a clinician working in a healthcare provider in the EU or Norway. So please feel free to contact us. We can get you online in about half an hour. And then you can request a case discussion. This is completely free of charge, and we are delighted to be using our CPMS version 2.0. So, any excuse to test it, we'd be delighted. And then finally, I would like to mention we also have a fantastic book that's been published by Elsevier on rare and complex urology. So please look that up. It's full of all the latest scientific knowledge and evidence. So, for tonight's webinar, we have adrenal cancer and malignant cysts. And it's a great honour to welcome our two presenters here this evening, very active members of our network, Professor Hans Langenhuijsen, and he's a urologist and a professor in adrenal surgery at the Department of Urology in Radboud University Medical Centre in Nijmegen in the Netherlands. And his research interests are innovations in diagnostics, perioperative imaging, and personalization of adrenal surgery. And again, I'm delighted to welcome Assistant Professor Nikola Knežević. I hope that was okay. And he is also a urologist working at the Department of Urology at the University Hospital in Zagreb in Croatia. So we're delighted to have you both here this evening, and I will give you the floor. Thank you.
So good evening, everyone. Thanks for joining today's EUROGEN webinar. So the presentation consists of two parts. First of all, I'd like to discuss with you hot topics for adrenal cancer. And the second part of the presentation is by Nikola Knežević, who will talk about the incidence of malignancy in adrenal cysts, and also about the EUROGEN research project that we're currently doing. So for our presentation, first of all, I'd like to introduce you to adrenal cortical carcinoma, ACC. As you may well know, ACC is an extremely rare tumor of the adrenal, and the incidence is worldwide around 0.5 to 2 per million people, with a very aggressive disease character, and this leads to a 5-year survival rate overall of approximately 30%. So most of these tumors are large tumors. The average size is 10 to 11 centimeters. And this means that open surgery at this moment is still the gold standard for these tumors. So it's important to be aware of the fact that the only chance for cure in ACC is a radical resection. So radicality is of utmost importance during these procedures. So how do patients with an ACC present themselves? We quite often see local mass effects in these tumors. So many of these tumors lead to pain complaints. Patients have weight loss, abdominal complaints, quite often problems with eating. And this is something we see very often with presentation. It could be an incidental finding, but these tumors are most of the times much smaller than these large ACCs. And there could be hormonal overproduction. So it's extremely important to discuss these patients in your multidisciplinary team. And as you can see here in the flow chart, you may know that the adrenocortical hormones are being produced from the primary cholesterol through several steps. The aldosterone, cortisol, and testosterone, and also estrogens are being produced. And in these in-between steps, you see these precursors of testosterone, for instance, dihydroepiandrosterone and androstenedione, which are often enlarged within ACCs. And we also see sometimes some genetic predisposition, for instance, in Lynch syndrome, but that's even more rare than incidental ACCs. So classically, we stage ACCs within the NSAT stage system. The NSAT stage system consists of 4 stages. So as you can see here, stage 1 and 2 are localized tumors, and the cutoff for these tumors is 5 centimeters. And from NSAT stage 3 upwards, these are infiltrating tumors or with lymph node metastasis, and stage 4 tumors are metastatic ACCs. And as you can see in the 5-year survival rates, there's a dramatic decrease in survival in patients with higher NSAT stages. So once you have a suspicion of ACC, there are several steps we need to take. Again, we should discuss these patients in our multidisciplinary team with an endocrinology department and do a proper biochemical assessment of these adrenocortical hormones. So cortisol is being measured, but also the precursors that could indicate ACC, for instance, the androstenedione and also progesterone. Further, we should do a thoracoabdominal CT scan with intravenous contrast. And as you can see here in the image, these ACCs quite often have a typical configuration with central necrosis. As you can see here on the image as well, there's also calcifications here within the tumor, and then you have a peripheral enhancement of the tumor, which is quite often seen in ACCs. So the Hounsfield units are high, specifically on the non-enhanced CT scan images, and the washout of contrast is very slow, meaning that the arteries within these tumors leak contrast on the very small arterial basis. So quite often we see with presentation already vascular invasion of ACCs, and in about a third of the patients we have synchronous metastasis as well with presentation of the patient. So sometimes it can be of additional value to do MRI, specifically to look at venous ingrowth and to make an estimation of ingrowth of the venous thrombus into the caval wall. And you should do FDG PET scanning as well to see if there is dissemination of the disease and there are distal metastases. So, and if we do have incidentaloma and we consider ACC because of its characteristics on radiological imaging and also because of hormone production, there is a clear relation between size of the incidentaloma and the chance for ACC, which is extremely low when the tumor is below 4 centimeters, but specifically above 6 centimeters, the chance for ACC increases dramatically. So I'd like to present you one of my patients. She is a 68-year-old female patient who was seen on the outpatient clinic with complaints of abdominal pain. She had weight loss and some problems eating. And on thoracoabdominal CT scan, we found a left adrenal tumor. She was also referred to the endocrinology department. They did a biochemical screening and they found that, as I told you, the precursors of testosterone, dehydroepiandrosterone and androstenedione were significantly increased. So then for dissemination, we performed FDG PET scanning. As you can see, here are the images of the CT scan and the PET scan. And we found that it's a localized tumor. There's no signs of clear infiltration of the tumor. Again, you see this typical appearance with central necrosis and peripheral enhancement. And on PET imaging, you see this necrosis as well. And there were no signs of metastasis. So briefly about surgical approach. So the principles of ACC surgery are clear. We should do a radical oncological resection. This is of utmost importance because the only chance for cure the patient has is a proper radical resection. So quite often we do en bloc resection of the tumor, including the periadrenal fat, and quite often containing the kidney as well, the spleen and or pancreatic tail. And specifically, it's important to do a radical resection with the periadrenal fat because in a significant number of patients of whom you think it's a localized disease, NSAID stage 4 are in fact upstaged after definitive pathology to NSAID stage 3. And also from stage 2 upwards, you should do a lymph node dissection. So specifically, the renal hilum lymph nodes should be resected in these patients. So this quite often means open surgery, but it's also feasible laparoscopically or with robot surgery. So in general, when there's a small tumor below 6 centimeters and you see it's confined to the adrenal on preoperative imaging, laparoscopy should be feasible, but should always have, let's say, a low sense of strategic conversion if you find it's not oncologically safe to do this operation laparoscopically because you have one chance only. And again, the lymph node dissection is of importance specifically in NSAID stage 2 patients and upwards. So we had a consensus meeting several years ago, and then in this meeting we discussed who should do these operations, and in general the opinion was that very experienced surgeons should do these laparoscopic approaches, and experience then is called 15 adrenal operations per year. And my advice is to do a transabdominal approach because of the space restrictions when you do retroperitoneal surgery. So if you have a clear suspicion of ACC on imaging and on biochemical aspects, you could do a laparoscopic approach for experts when the size is below 6 centimeters, but above 6 centimeters or with clear signs of infiltration, the recommendation is to do an open approach. And also for local recurrences, which quite often recur in this disease, it's still beneficial to the patient to have a radical resection because it benefits the survival of the patient. So then again, for local recurrences, the recommendation is to do an open approach as well. So in our consensus meeting, we discussed about volume, numbers we should do as expert surgeons, and it appears that there's a clear effect of case volume on morbidity and on survival, and trained surgeons do better on outcome of the patient. So the common opinion is to do ACC surgery in referral centers like in ours. And we see that in higher caseload, you have a higher chance that you have oncological sound resection without positive surgical margins. So improved outcomes are seen in dedicated teams, multidisciplinary teams, and you should have a vascular surgeon in the vicinity and a surgeon with experience in both pancreatic and liver surgery as well. So what do we know about positive resection margins? That especially when it's intraoperative tumor spillage, so R2 resection, that has a dramatic effect on both survival and recurrence rates, which are very high. So again, you have one chance for sound oncological resection, and that is that specific first instance of operation. So how about the role of laparoscopy? Again, if you're an expert, it's feasible, but there are some conflicting reports in literature about laparoscopy in ACC surgery. To my opinion, these are somewhat older reports in literature talking about tumor rupture, peritoneal carcinosis afterwards, and early recurrences. I think nowadays, in these eras of more experienced laparoscopic surgeons, it is possible for localized tumors, but you should be very experienced and do a lot of adrenal operations. So there's no randomized trials between laparoscopy and open surgery for ACC, and the advice is still counted over 6 centimeters to do open resection. So how about prognosis? We nowadays depend on the modified S-GRAS score. So this is a 5-point scale score in which we score for the stage of the tumor, for the grade, so the mitotic activity, the resection status of the tumor, the age of the patient, and whether or not he or she has complaints. So this comes to a total score of maximum 9 for the S-GRAS score, meaning that from 4 points onwards, there's an indication for adjuvant therapy, in this case, mitotic treatment, and even from S-GRAS score 6 and higher up, you should consult your medical oncologist to treat with triple chemotherapy adjuvantly together with mitotic. So back to our case, our female patient, we performed an open resection en bloc with the kidney because it was adhered to the tumor during surgery. We did a full renal hilum lymph node dissection. And to us, this indication for surgery is urgent, so we always operate within 2 weeks when we find these ACCs. We had a complication during surgery. There was a diaphragm tear. This was recognized during the operation, and it evolved without any consequences by repairing the diaphragm tear. So our pathologist found that it was indeed adrenal cortical carcinoma. It was 15 centimeters in diameter, and it was stages NSAID 2, so there was no infiltration of the kidney. There was clear adherence, so we removed it en bloc, but there was no infiltration of the kidney, and the lymph nodes that were removed were all negative, and also the resection margins were negative, and we found that the proliferation index was in fact quite low, below 5% of Ki-67, so there was no indication for adjuvant mitotic treatment according to S-GRAS score. So I would like to conclude this third part of the presentation about ACC. I hope I gave you an update on current standards of diagnostics and complaints the patient show us. And it's important to remember that this needs a multidisciplinary approach. So you should discuss your patients in the MDT together with endocrinology, radiology, pathology, and do a full hormonal assessment in these patients. And of course, the radiological workup is also really important. So until now, open surgery in general is still the standard for ACC surgery. And I hope we'll see future developments within the urology context. As you may know, We have registries, so we fill these databases with European patients with ACCs, which are extremely valuable data for future research. So thanks very much for listening, and I'll be glad to give the floor to Nikola Knežević after me. Thank you very much.
Good evening. My name is Nikola Knežević. I'm coming from University Hospital Center Zagreb, Croatia, and I will share some data about adrenal cyst, especially on the focus on incidence of malignancy in adrenal cyst. So I don't have any conflict of interest to report. Actually, there is not a lot of data about adrenal cyst. We know that they are rare lesion. Based on autopsy data, the incidence in general population is quite low. It is 0.18%, and they present 4% of all adrenal gland masses, about 2% of adrenal incidentaltoma. They're mostly benign and asymptomatic, and they're usually divided in 4 types. The most frequent are endothelial cyst and pseudocysts, which present about more than 80% of these cases, and much rarer the epithelial cyst or parasitic cyst. As I said, there's no lot of study about adrenal cyst. The most recent come from Mayo Clinic from 2022. Even for the Mayo Clinic, they present single center study of 92 patients in period of 20 years. So even Mayo Clinic does not have so many these cases. What they found and focus of this study was on the radiological characteristic of the cyst. So they're mostly incidental, like in all other study, 88%. They're non-functional. They're usually on one side. Median size of these cysts about 48 millimeters, range from 5 to 200. And because they follow the half of this patient operate, the half they follow, and they found that usually grow is about 2 millimeters per year. About radiological characteristics of this cyst, they find the shape usually round or oval lesion. Edges are usually clearly defined and thin, about 2 millimeters. About the structure, they're homogeneous in 83% of the cases. Calcification quite often present in up to 64% of the cases, most often peripheral. The density median is about 19 Hounsfield units, and usually we don't have contrast amplification intracyst. So based on this, they said what could be the typical finding for benign cyst, that low heterogeneity without contrast enhancement and hormonal activity really rare. Because usually what we have to think it is to differentiate the benign cyst from cystic pheochromocytoma or cystic carcinoma. We said there's a huge difference, radiological difference among benign cyst and this entity of adrenal glands. What about in the incidence of malignancy in adrenal cyst? Even in Campbell, it is written that this incidence is quite high. If you look, it goes up to 77% of this incidence of malignant cyst. Even if you ask to ChatGPT, the answer is the same. The basis for this high incidence actually are quite old studies. The first one is even from 1966 from Foster, and the most recent is from 1999, which based on an analysis of 515 cases, the incidence is 70% of malignancy. When we look to these studies, these data are based on diagnostic imaging methods which are outdated by today's standards. So sometimes what we know in our everyday clinical practice that there is no such high incidence of malignancy in adrenal cyst, but nobody proved that. So nobody made the study, which surely shows that nowadays, with use of modern diagnostic imaging techniques and preoperative hormone workup, this incidence is really not 70%. So our hypothesis that nowadays that the incidence of malignant adrenal cyst is significantly lower than the historically reported rate of 70%. It is the reason why we start multicentric study. So far, I include several centers. Our center, the center from Nijmegen with Professor Langenhuijsen. We also have, what is great, we have a Langenhuijsen center from Florida, from USA, and these are really high volume centers. They perform around 600 surgeries of adrenal gland per year, which is really high volume. And recently we include also the center from Slovenia. So the primary objective of this multicentric study is to assess the incidence of malignancy in adrenal cyst using a modern imaging technique. And we want to obtain, by pulling data from multiple centers, to get the more than 100 cases, so we can get robust data set which will reflect current clinical practice and imaging technologies in dealing with adrenal cyst. So this is study design and methodology. So this is retrospective multicentric cohort study. All patients with diagnosed with adrenal cyst from 2000 to present could be included. Inclusion criteria that diagnosis have to be established or via in contrast enhanced CT or MRI. One group will be perform operation. We have histopathology, which will confirm really what was pathology of this cyst, or if there are follow-up, that we have sufficient follow-up at least from 3 years. Exclusion criteria: the patient which will not be diagnosed with use of non-contrast enhanced imaging techniques. The data that we will collect is patient demographic, age, sex, and comorbidities, imaging findings, size, and characteristics of the cyst, operation, of course, histopathological results, type of cyst, and if they are not operate, the data from follow-up, at least follow-up from 3 years. And from this follow-up, if they are not operate, the reason why we do operation or why we don't do operation. The main goal of this multicentric study is to get the data that nowadays in the incidence of malignancy with use of modern imaging technique. So the reason why we start this study, because when you look to the literature, then we know from our everyday practice that it's not such high incidence. So we first look to our own data. So we make analyze the patients from 2011 to 2025. So we found 28 operated patients and 7 patients who were followed. Among the operated patients, we have that it is almost similar number, the higher incidence, like the reported in the other study in female patients. What is interesting to find, it is younger patients. So median age of this group of the patients 40 years, range from 19 to 71. It is quite high, quite big. Median cyst diameter is 71 millimeter, with range from 35 to 170. The most common indication in our group of patients, the size. It is majority of the patient, and when we done hormonal workup before operation, they are not hormonally active, and when we look to radiological look, the most in the half of the patients, we found that the simple cyst without additional radiological characteristics or findings in 15 patients. The most common, what is said also in the study of Mayo Clinic, is calcification, heterogeneity, or septa. When we do operation histology finding malignancy, there is no malignancy in our group of the patients. Almost in all patients, histology finding was endothelial cyst in 27 patients, and just in 1 patient we have calcified pseudocyst. The type of operation, in majority of the patient, we do laparoscopic procedure in 86%, And in 3 patients, we do robotic operation. Just in 1 patient, we do open surgery. So the type of operation, what later we can discuss. In the beginning, we do total adrenalectomy, or even some patient when we see that the simple cyst fenestration. But because of high recurrence after fenestration of the adrenal cyst, nowadays, in majority of patients, we do partial adrenalectomy. In the patient in which we do monitoring, so it is not big number, but 7 patient, median age again, young patient. When we look to the size, it is smaller size than in operate group of the patient. It goes from 10 to 73 millimeter. Simple cyst, again, we found about in half patients. Additional radiological characteristics, we find dense liquid in 3 patients, calcification in 1 patient. So median follow-up is 25 months. In 3 patients, we have regression, but not significant. Also in 2 patients, increase. In 2 patients, there is no change in the size of the cyst. So later, what we can discuss, because there is not surely data, what should we do? Should we do indicate surgery, and what could be indication for the surgery? We could discuss could be radiological characteristic of the cyst, age of the patient, because we see that majority of this patient, the young patient, the median age is about 40 years. The size, it is usually the reason why we do this operation, and because size is connected with the symptoms of this cyst. We also have to think about the patient idea that they have something like 10 centimeters big inside of them, and they just wanted to remove their young patient. After that, we have to discuss what type of surgery we should do. Is it enough to do? It is because of the high chance of recurrence fenestration. Usually is not good choice to perform this type of surgery, but we could discuss, shall we do partial adrenalectomy or adrenalectomy in the case of additional radiological findings like calcification, heterogeneity. Maybe it is clever to do total adrenalectomy. Also about the access, should we do laparoscopic operation, robot operation, especially if we do partial adrenalectomy or open surgery, especially because it is in the case of big cysts with suspicion that could be malignancy inside. So conclusion, actually it is based on our data and preliminary results, the incidence of malignancy analysis surely is not, it is much lower than 7%. And of course, this is the conclusion based on limited number of the cases. For definite conclusion, we will be waiting the data from other centers so we can make much stronger conclusion. And based on our data and the data from my clinic, we can say that monitoring is also a safe option because they follow from in their group from 92 patients, in half of them, 46, they just do monitoring and follow up. So at the end, I would like to everybody to join our multicentric study. We would like to get as much as possible the data, at least 100, but if we have more cases, then our conclusion and our data, which will be much stronger. So join the multicentric study, and if you have any question, just free to ask. Thank you.
So those were the presentations. I would like to invite the presenters to join our discussion section. I can see Nikola, you're already here. Thank you for being here. For our attendees, you can type in your questions in the questions field. Like I mentioned at the beginning of this webinar, you can do that by an icon. So somewhere down below your screen, you can find a Q&A with a question mark and you can type it in there. What we could also do is you can raise your hand and I will try to unmute you and you can ask your question verbally if you like. So I can see that there's already a question in the Q&A. So Hans, Nikola, if one of you would like to read out the question, then you can start the discussion.
The first question is about ACC, so I think Hans should answer.
Yeah, sure, Nikola, thanks. So the question comes from Maranchak Joseph, asking which systemic regimen is the standard first-line treatment for advanced or metastatic adrenal cortical carcinoma. So as I said, with the higher S-cross scores, you have indication for adjuvant treatment. So this is in general mitotain treatment, but in the higher S-cross scores, 6 and higher, also EDP, so triple chemotherapy, etoposide, doxorubicin, and cisplatin. This is the standard treatment. And this accounts for metastatic disease as well. We quite often do a debulking operation of the ACC and then treat afterwards with systemic therapy. And the patient, in our case, goes to medical oncology for his treatments. And the endocrinologist treat the patient with mitotain. So it could be only mitotain, but also a combination depending on S-cross score. And yeah, basically that's it. So there's another question, Parmida. Shall I read it out? In which situation is a biopsy of the adrenal mass acceptable? And when is it inappropriate, especially when ACC is suspected? So yeah, I think that's a very important question to ask whether you should do biopsy or not. I did a webinar in the past on this topic, so specifically on the role of biopsy in general, I would say, but I'm curious what Nikola finds as well. But in general, we advise to not do a biopsy in a clear suspicion of ACC. And there's two reasons for this. One, of course, you are afraid of spread when you do a biopsy in an ACC. And the other main reason is that it's very difficult for a pathologist to diagnose ACC based on a biopsy alone. So basically, this is more or less impossible. So in general, yes, there's no indication to do a biopsy of a adrenal when you have a clear suspicion based on hormonal assessment, based on imaging for an ACC. What do you think, Nikola?
I can comment that only in the case of metastatic disease, when it is not feasible to perform surgery or something like that, that in that case you can do biopsy, because oncologists, they have to have pathological finding to start with systemic therapy or something like that, because it is really rarely that we do biopsy in such cases, metastatic disease, which they're not sure what is underground disease. There is suspicion, especially if hormones are not elevated, that in that case you can do biopsy, but otherwise I agree with Professor Langenhuijsen. Surgery is the first choice. You have to do surgery without biopsy.
And I can see another question. Is there any role for cystoreductive surgery in ACC?
I can take that question if you agree, because we do that because it is a special role that we in such cases, when especially when it is oligometastatic disease, then we do cytoreductive surgery, and even some cases after that we go for a few metastases, or we perform ablative technique of metastasis in the liver, or SRBT for metastasis in the lung. But surely it is wise to perform cytoreductive surgery when it is feasible. We do that. Hans, do you have, what is your opinion?
Yes, I agree. There's also some data on this topic from the US that you should do debulking resection when you're more or less able to remove 80% of the tumor or of the total tumor load. It's feasible to do a resection, especially of the primary tumor. So that is one reason to make systemic therapy feasible afterwards. And the other reason is that many of these patients have complaints, not only physical complaints, local complaints, but also hormonal complaints, for instance, hypercortisolism.
So that would be another reason to do a cytoreductive resection of that ACC.
There is another question: to what extent the surgery could be done in ACC in RT and I think retroperitoneal.
Right and left.
Oh, right and left.
Okay.
Right and left side, especially large size tumors.
So Professor
Yeah, please.
Langenhuijsen already told that sometimes you have to do splenectomy, you have to do resection of the pancreas, so depending of the size of the tumor and the filtration, or even with vena cava, you have to do even sometimes resection of vena cava, extraction of venous thromb. So Hans, do you have some comments about this?
Yes, well, I don't think size really matters, although these become very big sometimes. So I did a resection just last week, a 22 centimeter left-sided adrenal cortical carcinoma. These are huge tumors. So that is why I talked in my presentation that you should have surgeons stand by with experience, for instance, with pancreatic surgery, vascular surgery. But size really doesn't matter. But it could be wise to do a joint operation with a liver surgeon or a pancreatic surgeon. And the other thing, if it really tends to be big and there might be even ingrowth in the diaphragm, I know, Nikola, you have some experience with the thoracoabdominal approach. I personally, I don't do that, but that could also be a strategy to do radical resection, because still that is the most important thing that we should do, to remove it completely. What do you think?
For us at our department, we mostly done thoracoabdominal approach. We do it by ourselves because of that way. We, especially when it is really go high, it is sometimes it is hard to mobilize. So for us, it's thoracoabdominal. In the case on the right side, maybe we call general surgeon to mobilize the liver, so we can really be sure to extract. But often, depending of preoperative finding, we are good with vascular surgeon in the case when we have to do resection vena cava or pancreas. So it is not only in the field of urologists but also general surgery or other. You have to be really teamwork because it is big disease and often quite big disease with infiltration.
Another question is, do you think that we will be able to classify adrenal cyst like renal cyst, like the Bosnia classification after the study? Best regards and thank you for the great lectures.
So first, we would like to have to collect all the data what is possible to have, and after that, if we have quite enough cases, then we can try to make something like Bosnia classification for adrenal cysts, which could help. What's possibility that like Bosnia classification, that possibility that is below 10% or it is 90% it is malignant. So when we collect all this data and when we get as much as possible the data, I hope so that we'll be able to do something like that. Hans, what do you think about that?
Yeah, I agree, Nikola. Yeah, we should first gather these data of at least 100 cases, that possibly even more, and yeah, see what comes out. I'm not sure if we're going to be able to organize or define a classification that is asked for, but at least I think we can have a better estimation of the incidence of malignancy within our experience. Both yours and mine is extremely low nowadays with the radiological imaging. So I'm really curious what we find in these data. And I agree that, yeah, we should gather as many adrenal cysts as possible. So if anyone wants to join, please send us a message and you can join this study. So I see another question here, Nikola, maybe I should pick that up. The chance of mixing up ACC with the retroperitoneal sarcoma without preoperative biopsy? I think that's a very good question as well. And to be honest, it happens once in a while, but the chance is not that high to my experience, because we quite often see the ACC patients have hormonal overproduction. So they either have hypercortisolism or the precursors of testosterone are raised. So yeah, I think we have, based on clinical signs and symptoms and hormonal workup, we have a good indication that it's ACC, and then we leave the biopsy. We don't do that. But you're right, it can happen. We had a mix-up and we removed the tumor. It appeared to be a sarcoma. On the other hand, I don't think that was really a bad outcome, because we did a radical resection. And the only downside could be that you would have offered preoperative radiotherapy in that specific retroperitoneal sarcoma. But in the end, you remove the sarcoma also. So yeah, but it's a very good question, I think. So, Nikola, would you like to comment on the next question, the lymphadenectomy in ACC, whether that is purely staging or whether it's curative? That's a good question as well.
It is a really good question. Actually, the answer we don't know, because it is rare disease. And even nowadays, there are some centers which are not high volume centers which don't do lymphadenectomy during the ACC. So we are hoping to collect the data from our register. We could get some answer about that, because even for some other disease, renal cancer, because we have to collect more data to be sure. But at this moment, I think it is much more staging than curative. Hans, what do you think about that? Because even we are not nowadays sure about the field of lymphadenectomy. We do renal healing, but I personally, if it is younger patient, I do much extend the field of lymphadenectomy. So especially it is hard on the right side to get enough lymph nodes. So even in this field, we hope for register that we'll get more data about that.
Yeah, you're right. It's very hard to get many lymph nodes. Once in a while, it's only a few. But I agree, there's some limited data in the literature saying that it's mostly staging purposes. We do see that the time to recurrence is somewhat shorter when you leave the lymph nodes behind. So it might have a positive effect on recurrence rates to remove these lymph nodes, but it seems that it doesn't have an impact on overall survival. So basically, I would say it's for staging purposes. So there's another question. Is there any role for metastasectomy after cytoreductive surgery for ACC? Nikola, what would you say?
We do that. When it is oligometastatic disease, when it is feasible, we do that. In the case, if it is not feasible to do radiologically, we do ablative technique, or even in some patient SRBT, we do, in the case of oligometastatic disease. But when it is too many metastases, then I'm not sure that is feasible and viable to do metastasectomy.
Yeah, we do the same when there's oligometastatic disease. We treat the metastasis as well, but in practice, this is not very often the case. So quite often these patients have many metastases. I've seen hundreds of metastases in the liver, for instance. So these are rare cases with oligometastatic disease. But yeah, for me, there's definitely a role for surgery then, because we know that these metastases are not really sensitive to any systemic treatment either. So you should always consider surgery in those cases. So there's another question from Marenchak Joseph. How many adrenal surgery centers are there in the Netherlands? And how many in Serbia? But you're not in Serbia, Nikola. So thanks for the perfect presentation. Yeah, you're welcome, of course, Manager. So how many centers in the Netherlands? I can start with that. So basically, until recently, there were about 35 centers in the Netherlands performing adrenal surgery, but we are a small country, so there's an advantage that we can centralize. So we are more and more centralizing this care for adrenal patients, not only for ACCs, but for adrenal surgery in general. So basically, at the moment, we are about 10 centers doing adrenal surgery in the Netherlands. And I think 10 up till 15 will be enough to do all these operations. And this is a mixture of urology and endocrine surgery. So that also this is a specific situation in the Netherlands. And this depends on the location. There's countries in Europe that have general surgeons doing the operations, and in other countries, urologists. And I know from Zagreb, it's urology as well. And I know you are centralizing as well, Nikola, but I'm not sure how many centers you have in Croatia.
Actually, we are lucky because at our hospital center, our endocrinologists are referral center for ACC and for pheochromocytoma, and it is we are mostly centralized in operation of ACC, pheochromocytoma, and metastasis adrenal glands. But in other centers, they do for primary aldosteronism, they perform that surgery, but they are not centralized. Especially, we run the study which showed that the result of ACC, which are treated in our hospital, they have much better prognosis than when they are treated, perform operation in other centers. So now it is mostly centralized, and I think that we operate 90% of ACC in Croatia at our department, 80% of pheochromocytoma, and 90% of metastasis. For primary aldosteronism, there are also other centers which perform this operation. So, but I'm from Croatia, so
Not to confuse with Serbia.
yeah.
So there's one more question, I believe. What type of incision do you prefer at ACC in open surgery? Okay, so well, I prefer a subcostal laparotomy. I hardly ever do a median laparotomy, but a subcostal incision. Maybe I know this because of my renal surgery. So I think that is an excellent exposure to the upper abdomen for ACCs. So that would be my answer, but I know you do thoracoabdominal approach, Nikola. But if you stay in the abdomen, would you go for a midline incision or do a subcostal incision?
Yeah, I will do subcostal, especially if I have on the left side, which extends to adrenal vein to vena cava, then I have to do. And if I operate with surgeons, then they ask me to perform subcostal incision because they're familiar with that. Because they're always surprised when they come and see thoracoabdominal and they say and ask where is thoracic surgery. I said I'm the one. So
yeah. So when we do a right-sided operation, we extend the incision up to the xiphoid, so we better be able to do a liver mobilization. So that could help. And do you do chevron incisions, Nikola, or you just stay on one side?
We do chevron. We do chevron, and even they called it in some cases when it is really complicated. They also go chevron, and then they middle incision they make, so it is really open, like they call Mercedes sign. So because you have to when it is big tumor, you have to really have big incision, so that you are familiar in the case of the bleeding, which is often. You can have significant bleeding, say you can early access to blood vessels to vena cava and aorta, so you're in a good position to control all complication.
Yeah, that's for sure. And as I said before, you have one chance of a good operation, that is this first instance. And so basically the size of the incision is important because they should do radical resection, and there's no need to make too small of an incision in these cases, especially when these are tumors of 20 or 25 centimeters.
Thank you. I think those were all the questions. There were many. So thank you so much for being here for the presentations. It was very interesting. Some usual announcements again. So the webinar has been recorded, and I will be sending the link for the YouTube recording tomorrow to everyone who registered for the webinar. So you can always watch it back. And you will also receive a post-webinar survey. So for the live attendees who visited the webinar this session, they will receive a survey in email, I think. So if you can fill that in, you can help us continuously improve our sessions, but you can also leave a comment or last questions at the end of the survey. I will try to link also the other webinar that you did, Hans, with the biopsies. I will link that in the description of the YouTube video so people can watch that was as well. So yeah, I think that was it. I would like to thank you again and wish you all a very pleasant evening.
Hans, shall we go to backstage for a
Sure, yeah.
moment?
Thank you.
Thank you
Okay.
all. Bye.
Good night.
Bye,
Bye-bye.
everybody.